Marie-Hélène Chomienne, who has her degrees from Paris and the University of Sherbrooke. And she has a master's in epidemiology, which she completed here at the University of Ottawa. She's a family physician who's practiced in New Brunswick, Quebec, and Ontario. Her clinical work involves being a hospitalist at the Montfort Hospital, 8 outpatient clinics, and some house calls. At the faculty, she oversees the SIM curriculum, which stands for the Society, the Individual, and Medicine. Her research interests are in health status of Francophone minorities, maternal and child health in Africa, and mental health in primary care. Today, she's going to share with us the results from the Mind and Heart study, which was funded by Movember. So, without further ado,
thank you, Doug. Happy to be here. Long time no see. It's good to be back. I wish I could come more often. Next time I'll pick maybe the April or rather than every day. Thank you all for coming with all that, considering the weather. So, thank you, Doug, for the introduction. As Doug was saying, I'll be presenting preliminary results from the Movember study. And we'll be looking at mental health after a cardiac event in an immense perspective. So no conflict of interest. The research was funded by Movember Foundation. The study was approved by all the affiliated REBs, and it was also registered with clinical trials. So Mind the Heart study, the title was Best Practices for Prevention, Early Identification and Treatment of Mood and Anxiety Disorders in Men with Heart Disease. And we were looking to introduce a stepped care model to treat the mood and anxiety disorders in men after a cardiac event. And it was a feasibility study. So there were a number of phases to this study. We had different principal investigators. We had 3 provinces, New Brunswick, Ontario, and Quebec, because I practiced there, so we didn't know. Has nothing to do with it, but so Jalila Jbilou was the lead PI, and in Ontario was Jean Grenier and myself. Jean Grenier is a clinical psychologist. In Quebec, we had Paul Greenman, who's a clinical psychologist. We had different site investigators. In Montreal, we had Bianca D'Antonio, who's a clinical psychologist. In Ottawa, at the Heart Institute, we had Heather Tulloch, also a clinical psychologist. And at the Hull Hospital, we had Stéphane Kennedy, who's a cardiologist and scientist. So there were different phases in the Mind the Heart study. The beginning, the first phases was doing a lit review, looking at all the best practices in different areas. And in our qualitative phase, one of the part of it was to look at what the men had to say about their experience and see what their needs and whether this step care model that we wanted to introduce would be acceptable to the men, whether it was feasible. So we had group discussions with men. Also within the same objectives, we had, it's in French and English, I don't know if people are bilingual, but okay. And also we had semi-structured interviews with health professionals, managers, and administrators, but I'll just be looking at the men's experience for this presentation. So we wanted to have about 12 focus groups per province, so a total of expected were 36 focus groups. So the background, why this study? So we know that heart disease is very common. It's a major issue, health issue. 1.3 million Canadians report having a heart disease. We know that for men it's a bit different. More men report having heart disease. This may be changed a little bit. We are having more information on women's health, heart disease. We think it's very much misdiagnosed or underdiagnosed, so these statistics might change in the next 10 years. But we also know that men are more likely to die from heart disease, and this is 3 times more after 65. So this is also an important factor to the background of this study. Also, the coexistence of mental health problems after a cardiac event. We know that about 45% of people after a cardiac event may feel discouraged, sad, lose interest, feel defective, be angry, and of those, some, about 20%, 25% can have a major depression. Anxiety, about the same statistics, 1 out of 5, and PTSD, post-traumatic stress disorder, also some report from 24 to 48% after a cardiac event. So these are not negligible, and it's really important. It's often not diagnosed or not attended to. Why the importance is that it's clear that if you have a depression, if you're anxious, you maybe will not be compliant with what is expected of you after a cardiac event. We tell you to do so many things. You have to change your diet, change your exercise, change everything. And if you're depressed, well, you'll just not be compliant. Some don't even take their pills. But also there is a physiopathological issue to this, and that is clear. It increases having depression. Not sure about the rest, but I know the studies that they're having depression will activate the hypothalamic pituitary axis. So you're going to have increased level of cortisol. Your high blood pressure is going to increase. You're going to be at increased risk of a metabolic syndrome and increased diabetes and sympathetic activation. And also it's going to have an important action and activation of the inflammatory pathways, which are also contributing to the thrombus, which is going to cause arterial occlusion. There's going to be this dysfunction of the endothelium, and all the inflammatory pathways with the cytokines and the CRP is going to be activated. So all this is going to contribute to more cardiovascular disease. So here you have the summary of what I've just said. So you have the depressive illness. It's going to activate the sympathetic activation, the hypothalamic pituitary activation, cardiac rhythm is going to change, endothelial dysfunction, hypertension development, coronary vasoconstriction, left ventricular hypertrophy, pro-inflammatory cytokines, atherosclerosis development, and platelet activation, and all this can lead to acute coronary disease. So not negligible, and this is by our clinicians often forgotten. So this is why we thought that the study was important, that the prognosis also increases. So if you have depression, and because of all those pathways and the fact that people are not changing their lifestyles, morbidity and mortality is going to increase. So if you have a mental health problems, you are 4 more times likely to experience a new cardiac event. And for those who have suffered an MI and who will develop a major depression, some studies have reported up to 5 times increase of cardiac mortality within the next 6 months. So it's not negligible. We definitely need to attend to this, and we need to detect it early and treat it properly. On the other hand, there was the masculine specificity, and we know more and more we're looking at studies and results with a gender lens, and I think this is really more and more important. Masculine specificity, just for depression, we know that men do not express their emotions in the same way. They don't like to talk about it. And you'll less often see somebody who's going to be sad when he's a man, more irritable, more anger, more risk behaviors, more substance abuse. This is the way it's going to be presented. And within the study, we're validating in French an Australian scale, which is called the Male Depression Risk Scale, which is really looking at those specific emotions that men are presenting when they are depressed. And a lot of the work has been done by John Olive, who's in Vancouver, doing all the depression in men. And there's also this, what we call the boy code and the guy code. Yes, well, you know, young boys have to be strong, you have to be independent, you don't cry. And, well, the guy code, men need to focus on problem solving, they need to be performant, they need to show strength. So all this is interfering with the fact that they, A, are going to seek help, and B, that we are going to be accessing them. So we know they don't like to talk about their health and feel less about their mental health. So we thought that all this put together, cardiac event, men, and depression, was something that we needed to be looked into. So this is the intervention that we were proposing. So after an acute cardiac event, we would be giving to, I don't know if this works, it should be written somewhere, anyway. We'll be giving brief psychoeducation and self-management tools. So all patients after cardiac event who entered the study were receiving psychoeducation and self-management tools. We followed them up with different instruments. After 3 months, if they still there was depression or anxiety or PTSD, they were offered to come into a group therapy. The group therapy, was developed specifically for this study by Paul Greenman and Jean Grenier. And the particularity of this group therapy is we have, out of the 8 sessions, 5 of the sessions are with the main partner, the significant partner. So the first session is with the partner, 3 sessions just the men, and the last 4 sessions with the partner. If after that there were still some signs of distress on the instruments, they would be offered either individual CBT, cognitive behavioral therapy, or couple therapy. Couple therapy is really therapy with a couple, not because the couple has a problem, but because there's a lot of adjustment to be done after cardiac event in the couple. So this is following, in fact, the STEP care model that the UK has introduced for mental health disease. So low intensity, so you don't need to have, somebody who has a PhD to be doing that, and that this can be very sufficient to help men or women after a cardiac event. And then you go to a moderate intensity, where there you have to have usually a psychologist. You may have counselors if they're trained to that. And we've also, with the study, we've developed an online course for this group therapy. And then you go to high intensity, where it's a one-on-one, where you see the psychologist for individual therapy. So this was the STEP care model that we were proposing, and that we were looking to see whether it was feasible. So going back to the focus group and our qualitative phase, so it was a phenomenological approach. So it's really because they're looking into the structures of the lived experience of those patients. It's really what's coming out of their experiences and how they lived through that, and looking at that through a gender lens. And after that, the results were really to inform the STEP care model that we were going to implement. We used a purposeful sampling. Men needed to be 18 and over in Ontario and Quebec. In New Brunswick, the majority is 19, so it was over 19. They had to have a cardiac event in the last 5 years, with or without a mental health issue, and were able to read and speak French or English, and they were available to participate in the group discussions. So we developed for that a focus group guide, and we did a lot of training with the interviewers to be sure that everybody was, the 3 provinces was at different sites, to be sure everybody was on board. There was a clear guide to not what we were expecting, but how to put it, and what was also, because they had to present the model, they really need to know what the model was and what was the objectives. And we did the recruitment through posters, media, social media, cardiac rehabs, mental health units. All the patients signed a consent form and also signed a confidentiality form.
And just to be clear, so the groups, so those focus groups were to develop the intervention, because then you said about they'd have to understand the end. So maybe just
because within the focus group, the guide, there was that section where we were looking at what were their experiences first. During the discussion. So there was that section. And then after that, we went through and we showed them what the model would be and asked them to comment on this. So
they already had the model and they were
in the same focus group, but just reporting about their experiences there, and not reporting on what they said on the model. So they signed a consent form, and they also signed a confidentiality form, because people talk about themselves within those groups, and we tell them not to talk about that when they're outside of the groups. There was always 2 persons, 1 interviewer and 1 note taker. The interviewer was always 1 researcher, and they were audio recorded with 2 recorders. The participants, their parking fees were paid. There was a light snack, and they also received a $20 gift certificate. The data collection, so we collected that between May and September 2016. Recruitment, as always, was a bit problematic. It took a lot of time, always more time than we do in Spain. And we carried out, so whether they had a cardiac disease with or without mental issues, they were all eligible, but when we carried out the focus groups, we put them all together in different groups. So all those who had only a cardiac disease on their own, and those with a mental health disease, so as to keep as homogeneous as we can, the groups. So audio taped, they were transcribed, took a long time, because in the budget, there was no budget for the transcription. So It was very, very much an issue. It took about a year. By the time we had a lot of students trying to transcribe that, and finally we all sort of put in some money to get this transcribed because it was taking forever. It's a lot of data. We had 20 focus groups, about an hour and a half to 2 hours and a half each, so it was huge. So we did a thematic analysis of the data, and we used also open coding and created codes to try to capture the most of the emerging themes. So we had, we also had a guide to see exactly how we were going to manage this process. We had 2 analysts who were looking at the data, and we also did a interpreter reliability check to be sure that they were also on the same page. We calculated the code coefficient. It was over 80% or more. We were confident that they were coding approximately sufficiently in the same way, and all the data was analyzed with the support of many people. It's huge work. You think quantitative data is hard, but qualitative data is really a lot of work. So I'll be presenting some of the preliminary results from this. So, and I'm just reporting Ontario and Quebec. I didn't have the New Brunswick data. So all this was gathered between May 2016 and September 2016. We had a total of 20 groups. Somehow we did lose 3 recordings. We don't know how this happened, but 3 recordings were lost, or they weren't transferred to the computer, whatever. Anyway, in Ontario we had 14, but only 11 recordings, and a total of 69 men, which makes about 3.5 men per focus group, which is about the limit. I think there was one. We had just only 1 man, so it was, in fact, it's more like a semi-structured interview than it was alone. That's about it. So what are the participants like? Most of them are 65 and over. 50% were 65 and over. Most were married or with common law, so 54% married, 22% common law, so that's about 75% were able partners. Highly educated, 55% had a university degree. Most of them, 65 and over, were retired, 78%. We had an oversampling of the francophones, and 58%, and most of them were white Caucasian. So we gathered that about 5 main themes emerged from this. There was definitely the shock and the disbelief. There was a sense of vulnerability, the impact on the identity, the perception of self. Emotions, there was a lot of fear, feeling of solitude, feeling of sadness. There was a lot of adjustments to this new identity, this new role that they had. And they did share the fact that those emotions were not attended to at the time. So what did the men say? So indeed, they do report shock, surprise, and disbelief. One said it was really an accident. It came out of the blue. It came as a bit of a shock, even though I had hypertension. I suppose it did come as a bit of a surprise. One reported that it was really a confrontation with death. A lot of people, he says, don't think about death. They think it's really too far away, but suddenly it just falls on you like a ton-up brick. And the other guy saying, well, you know, I experienced those pains, but I thought it was a joke. So a lot of disbelief, shock, not really coming out of the blue. And also the emotions, the sadness, the solitude. And a number talked about suicide. He really thought about it. He really had a plan. He was planning on se noyer, drown in his pool. And he was talking about it. He was very, very. I did 3 of those, and he really was very still emotional after. In fact, it was about 10 years ago for him. So it was really emotional thinking about the way that he had thought about suicide at that time. And one saying also that they feel very lonely towards themselves, or their family, towards the medical world. They feel alone. They feel that very much. And a number came, well, later on we'll see, that they really find the interface with the medical world is very complicated for them. They don't understand what's happening. Mine was a freaking nightmare, and it was just a freaking nightmare. I didn't know what was going on, and it scared the hell out of you. Puis c'est surtout la perte de contrôle, the loss of control that they feel. I mean, the scary part is losing the control, and it's frightening. It's really frightening. It's extremely anxiety-provoking. It's frustrating and angry. And as a hospitalist, I see a number of them on the cardiac ward, and we really don't pay attention to that. It's just mind-blowing. We just don't. We don't talk about it. We don't ask. They come in, they have a stent, out they are, you're 100%, you're all good. The guy who's 40 years old, he doesn't know whether he can go back to work. Oh, well, the cardiologist told me I was 100%, yes, but all the rest. Oh, well, yes, nobody told you about it. So it is major what they do feel, and we're not looking at that. So the impact on the inductee, I think what bothers me a lot is that I'm only alive because of the pills. It changed my life totally. Like, you know, I was pretty confident. I was a supervisor, captain of all my team. Well, I wasn't there anymore, right? And like, it took something for me just to accept that I wasn't the same person. So this change of identity, this is going to take a lot of adjustments. So those roles are different. Well, a lot of times I got to bite my tongue because I can't do the things I used to do. What I found the hardest, I found it hard to stand there and look out the window and watch my wife snow blow the driveway and cut the grass. And, you know, I feel I could do it. So, you know, that really bothered me. A little thing, a little trivial thing like that. But it's not that trivial, really. It's the whole roles are changing within the dynamics of the couple, too. And they do find this very, very challenging because they're not understanding just what happens. And they don't know how to react or how to live with it. You don't know that you're going to be understood. And that's also something that they feel, that the loneliness, they don't, even though they will experience or they will maybe talk about it, they don't know if their partner or people around them are going to understand them, so they really feel out of it. So, but people adjust differently. We had one, he had all the major complications. He ended up with the interventricular defibrillator. Oh, well, he said, well, this is it. That's how it is, you know. Some people have glasses and I have this. So some are really easygoing, but he was not, he was more of an outlier. The others really thought this was very complicated adjusting. The first thing I would need to, I understood I don't always do this, but I have to have the courage to experience and express what I'm experiencing. And the other saying, well, I have a 14-year-old son who looks up to me. I'm sure I'm his father. So, you know, sometimes when I see him, you have to put on a game face because you really don't want to show how you feel to your children because they're going to worry. So there's a lot of redefining of the roles. You know, I don't want to feel dependent, but they know that they have. Their wife are doing everything. And he went golfing and the friends had to push the cart, you know. And I, as he said, they took on that role, but I had to accept that role. So the roles changed. And certainly the heavy work and the garden and stuff like that, I have now to accept. So there's this part of acceptance that they're different, they've changed, and they have to, as he says, draw a line, and things are different, and we have to have new roles. And most of them have to do this on their own because there's no help, there's no support. The support, what they reported from the support and to adjust to the challenges was essentially those who did go to rehab, but we know only 30% of patients who have a cardiac event go to rehab. So those who did go to rehab liked the fact that they got together because it was, as they said, de-dramatizing. You could see other patients who had the same thing, really like the peer support. And it was a point of reference to see others who maybe had something more complicated, more severe. And it was very helpful for them. And what I liked is the one who said, well, it really gave us a mode de vie plus conscient. We were more conscious of the way that we need to live. It was really, as a physician, when I did those focus groups, I really felt bad seeing all the distress that they've lived through and that they have with so little help. Anyway, so a lot of changes for those who had partners was really with the wife or the common law, and the fact that most often the wife had lived through the event with them. So and that's why it was important for us to include the wife or the partner in the therapy, because they also become stressed. They also live the stress that they had, well, he nearly died. And then, so when the patient comes back, or when the husband comes back home, he gets stressed out. If somebody has a bit of pain, stressed out, he goes out walking, he's not coming back, anything happened. So there is the stress of the wife, and so there's also, they have to, but they have to manage most of the things now, and they help out managing their pills and all that. But it's the dependency, it's the changing in roles. But most of them did say that having the wife there was really essential. They couldn't have made it without them. And it was really, they were there to help, to support, to encourage, and they were always saying, well, we're going to do this together, we're going to go through this together. So that's where they didn't feel so little alone. But sometimes, well, we had a problem where they sometimes overprotect, you know, and they oh, don't eat this, don't do this, don't do that. So there was a bit of a mix, but most of them really thought that the wives were really important. And then there's the issue of the sexuality, which we don't always talk about either, and this also changed a lot, because the cardiovascular disease or the diabetes or whatever, and also the pills, and that made a lot of difference, and men don't really talk about it. There was another one saying, well, it's really difficult to talk about these issues, even in the group, or mostly in the group. There was also the adjusting to the workplace. So it's not very frequent in the patients that we had because most of them were retired. But coming back to the workplace was also very difficult because they felt that they had to prove that they were still able to work even though they had a heart attack or a cardiac event. And what they sometimes thought, a number of them were in the government, and is that, well, the management's changed, the HR changes, so they have to always to re-justify the way that they're working, that they are maybe working less hours, but that they're still functional even though. So they thought that was a very difficult step also, and that workplace wasn't ready to rehabilitate them within the workplace. Now, whether these all these emotions were talked about, the majority no. As-tu une dépression? Non, on pose pas la question. People just don't ask the questions. Feelings? No, nobody asked me that. No, that was not, and back then it was not addressed. I mean, there was illusion that you know you're depressed and you're feeling sad. Well, you know, give us a shout and we'll help you. Yeah. And one said, well, yes, they would tell us to give us a shot and help you, but they don't really. Another one saying, I don't think it was treated as a specific issue. That is part of what it should be. It should be treated as part of cardiac rehab. So the health professionals, of course, some argued that, well, we don't have the time, we don't take the time. They often feel rushed and brushed off, and so no relationship is sufficient to be able for men to talk about this, to open themselves to this. Emotions, this seems to be like a time-consuming, expensive exercise that at least the professionals I've dealt with haven't been available for. So all emotions are brushed away. And did identify that we should be as professionals more geared to this. They should need more discussion about how mental things do impact what they're wanting us to do. If they think that the cardiologist really needs to know that if they're depressed, well, they're not going to follow the treatment. And others said that it would be important also to inform the family physicians. So a lot of gaps there. They do find that if they had the information, they would have used it because, as they said, it's not men who's going to go seeking for the help. They're not going to come and seek the information. And they do think that it would have been useful for them to drive away all these black thoughts. But there were some ones who did find that their family doctors were really helpful, that they really cared. So it was not all black for health professionals. So in summary, clearly having a cardiac event is a traumatic experience. It does engender a lot of emotions, which was going to affect the men's image, their identity, the role within their family, their friends, and their workplace. So this is major for them. They can't do it alone. And yet emotions are not addressed after a cardiac event. Or not sufficiently. The partners had an essential role to play, and it was interesting that during the focus groups of men coming who had a cardiac disease and reporting that they only had cardiac disease and not mental health, in fact, they realized through the focus group that they had had depression, they had had anxiety, which had not been diagnosed or attended to. Limits. Well, the limits, one of the limits that we found is that it was self-reported heart condition and self-reported mental health conditions. We did check with any instrument to see whether it was anxiety, depression, or something else. They was self-reported. We had a loss of data, but we had quite a number of data, and I think saturation was attained quite quickly. Maybe not representative of all patients. This is mainly retired patients, so maybe not as much impact. So they're older. Most of them had a partner too, so it's maybe interesting in another study or in another analysis to look at if there's any difference between those who have partners or not. But in the focus group, it's going to be difficult. Highly educated. So this definitely, I know from the patients I see that the younger they are, the more difficult sometimes it is because they have to be really performing and all that. So whether when you're over 75, usually, well, they know that they're not doing as much anyway before, so they're not doing all those activities, but for younger men, it is very traumatizing. So I think this definitely confirms that cardiac events do engender and have a psychological impact, which in turn has a psychological impact on heart disease. We know clearly health services, and this was confirmed also when we do the cross examination with what the professionals and the managers say, that we're not geared to answer to those emotions. We're not trained enough, and even the nurses or in cardiac rehab, it's not addressed sufficiently well. Men do acknowledge and are capable of acknowledging their emotions. They do say that they're sad, that they found it difficult, and they are open to receive help. And sometimes we always think that men will not come, but they are open if we go and ask them. They will answer to that. Importance of increasing awareness, so for patients and healthcare professionals, and improve our practices and offer the services. And this is, we have a website where there's a lot of information there. So any questions? I hope.
So I have a question, and I don't have a clinical background, that might be my limitation. But somehow, I guess a lot of the participants didn't recently have the event, and somehow was under the notion that there is a transition period, but that people are able. I didn't realize that they had to limit their activity as much as they're saying here. So, for me, it seems very clear that you're aware that you're now vulnerable. Anything can happen to you, and I get that. I'm having a little more difficulty understanding why they have such physical limitation. Is that normal course, or because I knew a few people who had a heart attack, and essentially they're told, get back on it, and so maybe help me understand that.
Well, it all depends on the severity, of course.
Okay.
So maybe those who came for more severe, but definitely after if you have a cardiac bypass, you can't go back working the following day. I mean,
no.
It takes about a year,
physically,
usually, about a year before you're back to normal activity. We will say that the surgeons will tell you 6 weeks, 8 weeks, but practically, the patients I've seen, and they don't get back to a normal usual self unless it's about a year. If you have a stent, some people feel so much better after that, and they definitely can do much more than they were doing before. But there may be things that they might not be able to do. And there's also the problem is the medication that we give them. The beta blockers that we give them also limit them a lot in their activities, in the physical activities, in their sexuality, and all that. So I think it's not always just maybe the heart disease.
Yeah.
But,
so it might be helpful to understand at what point post-event these folks were at. Because if they were within a year, then I'd understand their physical limitation. If they're longer than a year, then maybe it's the medication. So I think it'd be interesting because that.
Yeah, well, that in the focus group we couldn't do that at the beginning.
No.
We may see that with the quantitative results of the follow-up with the patients that we've had for a year.
Mm-hmm.
But whatever, I think for any disease, as soon as you're sort of tagged, well, now you have a cardiac disease, now you have this, and people change their attitude within themselves. They feel that they're no longer, and and people look at you also, and they see you. Oh well, you're a guy who's had a cardiac disease, who had this. As I say, some were saying, I don't go to the swimming pool anymore because then people look at it. Oh, you got a scar, you're cardiac. So they just try. One was going to do a tattoo to try and hide it because it's sort of mini stigmatization. Oh, you're cardiac. Can you do this? Can you do this? Are you sure you can do this? Are you sure you can go up the hill? So if it's not yourself, it's all the environment. They're always cared about the family, the friends. We didn't find that men were, there's a lot of data saying, well, men don't express themselves. They won't come and seek help, that's for sure. But if you go out to them and you outreach them, they will respond, all those that we had. But then there are all those that did come. Maybe we don't know. Those who refuse to participate, or maybe those who just are not interested. Yes.
Thank you. I'm just wondering, how did the findings inform the step care model?
Well, when
one
we
of the things that you said that really resonated with me was this idea of role change, role loss, role transition, and how you help people move forward to maybe changing the value they assign to particular life roles, or change within the roles within the family unit. And to me, that's
so what changed in the way it informed after that when we asked them is that for the psychoeducation, it's very difficult for them after an event to have more information added on. We had a pamphlet, they thought it was easy, but they needed a sort of a recall saying, well, don't forget you've received that if you want to go through that, because there's all the explanation. So when is the best timing to give this psychoeducation? So some would say, well, just before we leave, because the partner is going to come and see you. So then you have the two who are there and you can explain. So that would be a good time. Or 2 weeks later, once they've left the hospital. So the timing of that was something that we looked into. The other thing was the group sessions. Well, a lot of them at the beginning thought that 8 sessions would be long, but a number of them had gone through cardiac rehab, which is usually 8 to 12 sessions. So when we related that to them, they said, well, maybe, yeah, we could try that. They thought the partner was at the last 4 sessions. They wanted the partner to be there at the first session. So we introduced the partner at the first session. So these are the sort of changes that we made.
Hi there. I have a question about broader implications of your research. So do you think that maybe your preliminary results and later full results would maybe help to inform practice guidelines on how to manage patients post-cardiac event by maybe offering them an antidepressants or
Well, we wouldn't be offering an antidepressant just after that. I mean, we need, before there's the adjustment period, which is about 3 months, and that's why most of the patients will do well after the psychoeducation.
The step care, can you go back to the step care slide?
But the guidelines best practice does include screening. So screening all patients pre-discharge.
But we didn't screen the patients pre-discharge.
But
they all had
like guidelines for best practice.
Yeah.
It would be screened to identify the
Well, at
person.
least to talk about it and say, well, this is what may happen. You are going to feel sad. You are going to feel distress. Well, you may, because only 50% of them do, in fact. You may feel anxious, but this should be with psychoeducation. And this is the first step, the psychoeducation and all the self-management tools where we explain, well, yeah, this is going to happen. Don't worry. You're not the only one, etc. And usually after 3 months, the majority will not need any help at all. Now, there are those that will go on to have a full-fledged depression or anxiety or panic attacks or PTSD. We had a guy who just couldn't stand hearing the ambulances anymore. He went out to live outside way in the woods because he didn't want to hear that. So yes, all this is going to happen, but not in the first 3 months. But they have to, the most important thing in everything is to know what's going to happen. Understand what's happening and know that it can happen. You can get through. If not, then there's going to be help.
I'm wondering how this fits into like a broader integrated care model, because they talked about the rehab, and even one person suggested that they liked some of that subject was broached at the rehab, like they talked a little bit about the mental health. So, and I don't know, I interpreted that as, oh, you know, I was able to receive that when I was at the rehab. How do you see this fitting into, you know, other measures rather than like the rehab, for example?
Oh yeah, well, absolutely. Well, this is what we're working on. The next step is, you know, all the findings with the managers and following the way that we implemented that is definitely to present this to the managers in the different hospitals and definitely introduce, if not all of it, at least part of it. And definitely, we did a lot of training with the nurses on the wards and the physiotherapists and all that to be able to, you know, so that they could screen or that they could talk about it or that they could make them aware that this could be happening, to be able to talk about it, you know, with good information. So part of the psychoeducation, we hope, but you know, it had to come from up top, from the direction, the managers, to say that this is going to happen. So this is what we're aiming for, that it's integrated with the cardiac rehab.
Okay, so that's it. Yeah. And because the cardiac rehab is really more around the physical, like
primarily. It's more around the physical,
so
the
yeah,
diet
nice
and all that.
Yeah.
There is a little, well, at Montfort, I don't know, and I know now at the Heart Institute with Heather Cholok, there is a section on mental health, but it's definitely not as developed as we would like it. Yeah.
It was interesting seeing some of the themes related to one disease organ focused or one event focused, and you're talking mental health, role change, etc. This is much more than just the heart, and wondering about the shared care model and having acute care introduce self-management tools, brief education, and part of the discharge planning is what has been introduced and what might be picked up on by other people working with the patient. Is trying to find a way to bridge cardiac care to primary care. When what you're hearing from the patients is this was focused on one event, but afterwards I'm feeling a whole lot. That event is over, but I'm still reeling from it.
Well, that's
the add to that too. Like, I don't see where the cardiologist fitting.
Where the cardiologist?
Yeah.
Oh well, they need to use the cardiologist to know that their patients are going to be depressed, but they just don't want to talk about it. So well, the cardiologist, but you know, there's all the care. There's the care with the cardiologist, the guy who puts in the stent. For him, he's done his job and everything's fine. He's 100%. He can go back to work. But no, that guy cannot go back to work. That's not true. So introducing mental health care and integrating mental health care, whether it be at a cardiologist level, whether it be at a primary care level, I mean, that's major, and that's who's going to give the care. Are we going to add more to the physicians to be doing again? If they need a psychologist, if they need a counselor, where are we going to refer? It's always the same thing. So it needs to be integrated within what the system is offering, and how we can do that. So our best bet is really through cardiac rehab, or at least to have some sort of self-management tools for those first 3 months. At least if a patient is aware, he'll know where to go and knock on the doors once he knows, well, you know, this has gone too long, or his partner knows, and then I'll go and see a psychologist, I'll go and talk with my family physician, and I'm going to ask him to do this. But if he doesn't know that he has to do this, he won't do it. So the best bet is really to inform the maximum the patient who's then is going to put the leverage, and they're really going to open doors. Because as a family physicians, we hardly have time to address even those issues. We can talk about it. We'll listen definitely more often than maybe the cardiologist will. But I think we're so overwhelmed with work. I think adding on more again, you know, it has to be very focused the way. You know, I've been looking at integrating primary, you know, mental health and primary care for the last 14 years, and it's what we're asking the family physicians. It's always more and more. Now for cancer, they're not going to follow the cancer patients anymore. They're going to tell you after 1 year, well, now it's your family physician doing this. You hear something, this is something new. Oh, well, the family physician is going to do this. So we have to find a way where the patient knows what he needs. He comes in and tells you, well, you know, I thought things out. I've had this information. The Heart Institute has told me this. I need a psychologist. Give me a psychologist. Because we won't have time. And unless we have, you know, shared care models, it works when you have the money. The money is not there.
And the money isn't there for the psychologist either. For the majority of patients, they
majority of patients don't. I know. Well, now you have do we have all those online web things that they've bounced back and all that?
Yeah, but so that's one of the challenges for cardiologists. Now the evidence is in, mental health is clearly impacting cardiac outcomes. It is a part of cardiac care, but they would say, so we screen for it, we don't know what to do. We don't have psychologists in our unit for the most part, and we don't have any training in mental health. Primary care, you're used to being generalists, you're used to doing everything. You do it, so you screen post-event, and then you pick it up. But you've developed a step care model that does not require expertise in mental health care. It requires expertise in orienting a patient to resources, self-management tools, brief education. It is not engaging in psychotherapy or being able to offer mental health care. It is directing patients to resources where you could say that is very clearly within a cardiologist's expertise. But you can't ask cardiologists to do mental health. You can try, but it's like asking family physicians to do more of anything, right? But some of these interventions are not actually delivering mental health care. It's no different than orienting to resources for physical activity, orienting to whatever. We're not saying you need to be an OT or a kinesiologist. And so it's trying to lodge the stepped care where it can be comfortably absorbed by the skill set, not asking people to develop more skill sets, except if you're primary care, because that's expected.
Yeah, well, we did speak with this cardiologist. We did give out all the handouts and the pamphlets, and they have access to the website there. Patients can go there. For the moment, that's all we're doing. The rest, our next step is really trying to integrate that within the cardiac rehab once we finish analyzing all the data, because the managers will like to see some data that it is effective and it's working, and that this is what the needs of the people are, the patients are. So it's really to integrate that.
Interesting comparison would be what happened to cardiac care when performance measures were introduced for aspirin before discharge, beta blockers, some of the medication management that needed to be done prior to discharge, and how in the span of 2 years, I think there was a dramatic improvement, largely in the US. Could you create a box that is orientation towards psychosocial support and self-management tools?
We're going to work that with the nurses on the units.
So that there's a discharge tick box.
Tick box, that this was said, this was done, this was given.
And see whether there's at least an increased uptake in delivery of that first orientation.
I'm interested in why and what benefits there were from your focusing on men. Generally.
Well, you go where the money is, right? So it was
That what it
November,
was?
right?
Well, there's been a lot of criticism
It was November.
of researchers restricting, historically research to men and under representing.
Well, there were
women and
different
so on.
issues. From my experience, well, it's very limited, the patients we have on the ward. I find that men usually have definitely more difficulties. They do come with more severe disease sometimes. And I find that sometimes our approach, working with Jalila and John Oliver, our approach is really not men-oriented. The way we deliver the message has to be delivered in specific ways, using specific statistics or whatever. They want to be approached differently. So I find, and men really need a different approach, and sometimes we don't differentiate that. Yet we know we do adapt when we have them in our office, but I mean it's not sufficiently well known that you need to adapt to men differently. And the fact that they do not express their depressions in the same way. When you look at the RICE scale for men, it's really risky behaviors, substance abuse, alcohol, aggressiveness. It's not what we're used to seeing when people talk about depression. He's sad, he's staying in his zone, he's not moving, he's there. That's not it usually. They become aggressive. And they do become aggressive once they've had their heart attack. Oh, I've got those pills, I don't want to stop eating, I don't want to do this, I don't want to stop my smoking and all that. They become excessively aggressive, and this is sort of an expression of their sadness. So I think we need to get it out. And a lot of people don't know, when we talk with the nurses on the wards, they had no idea that that could be the signs of depression, and it's clear. So I think we need to, and women have a different way of expressing, and women also take a long time before coming back. We also always think that men do not seek behavior, do not come to the emergency. Women are even worse. It's, oh, it's nothing. And the symptoms are not always as bad or severe.
Yeah.
Oh, it's nothing. I've just sprained something. I'll go on see tomorrow or later. Or they come 2 weeks later. So I think we have to look at things differently for men and for women, for a lot of things. I don't know. I mean, the more we do the gender lens, the more I see
And
different things.
CIHR certainly thinks so. We have to take that lens in everything we do.
So men was A. Well, I wanted, well, after all the men that I saw, there was that poor guy at 40 years old. He had 3 stents put in, and he was just, staggered by what was happening. Didn't understand what was happening to him. And they were saying they never understand what the doctors say. For them, it's definitely too complicated. They listen, they say yes because they don't want to disappoint us. But that poor guy, he's stuck in my head. He was 40 years old. Nobody had told him if he could go back to work. When, what? I'm not the cardiologist. Well, I had to do it, but I mean, no one from the cardiologist to the one who put his stents told him anything, or so he said. But anyway, and no one asked him, well, how do you feel? Oh, he told me I was 100%. Yeah, the doctor told him he wasn't 100%, but the patient, is he 100%? Really not. And that really stuck in, and well, so I said, we need to do some work on that. It wasn't a personal stillbirth, but it was a personal experience for the patient, and I thought it was very distressful. We need to help him more. And then when you come out with the statistics, and you see how much it impacts the heart disease when you have depression and anxiety, it's major. And we've known this for a long time. I mean, the lit reviews that we did, this depression at the Heart Institute in Montreal, we've known that since '98. It's not new. Any more? So our next steps is we're finishing the quantitative data. The follow-up of the patient will be finished in March and June of this year. So after that, we'll be able to analyze what's been happening and how the people. We've already done a number of focus groups for patients who participated in the group therapy. They were really very, very happy with what happened. And they loved the fact that the women were there too. So it was and the way they set it up, Paul and Jean, it's really impressive that. So the online course is going to be available soon. We finished packaging everything up. So if we want counselors to have a look and follow the course, then it's going to be there for the group therapy. So oriented for cardiac events and for men. Anything else?
Online?
Online?
No,
No?
online.
Okay. Thank you.
Great. Well, big thanks to Sarah and Marie-Hélène. Thank you very much. If everybody can please fill in your evaluations, and just to note that the February Grand Rounds will feature Doctors Kevin Potty and Sharon Johnson. There we are. That's me. I'm up.
She said something.